what stems and when to use them. Now the main topic is whether to use cemented or uncemented, and here is the slide. If you understand this slide, you've got the differences. So this is the very important slide. Let us look at the pros of using a cemented stem. It is relatively easy to insert because whatever defect you have, you're going to fill up with the cement. They are short stems. You don't really need to prepare too much into the canal. What are the downsides? You do need to pressurize in that metaphyseal area so that your stem has a good purchase, not only now, also when the cement actually contracts a little. Cement, when it sets, ultimately is going to contract. And in a revision scenario, you will have cortices which may be smooth. They may not be interdigitation. So you need to keep all that in mind and use the cemented stem with a good pressurization. You don't do that, it's not going to be a very secure fit. Also, removal is difficult. Supposing there is a failure, infection is easy because it will become loose, but otherwise to take out all that cement can at times be difficult. Particularly, it's not a very short but a little longer cemented stem. Let us look at the pros on uncemented stem. And I think this is the most important reason, is that it aligns the component. The moment you put a uncemented stems, which goes deep down into the canal, you've reamed the canal, now it affords you the alignment according to the anatomical axis. And therefore I use it all the time because I don't need to really, in a revision scenario, fall back on my navigation. Unless it is a uni-revision, I don't use navigation because even if I make my cuts based on the navigation, ultimately it's the stem which is going to dictate my alignment. And so I think the biggest advantage is that your uncemented stem will give you your alignment, both on the femur and the tibial side. However, on the femoral side, sometimes it is difficult because your canal, it may not be a completely canal filling stem, but on the tibial side, all the time it will give you a correct alignment. And removal is relatively easy, relatively. You know, the uncemented stem can get incorporated in certain area and may be difficult, but at least you don't have to take out the cement after it comes out. What are the downsides? Long length is required. Most of the time to get a purchase, you can't put a metaphyseal uncemented stem because you'll have no purchase there. You need to get into the diaphysis. Not only into the diaphysis, you need to get into the area where there is a relatively uniform canal. You don't want to be touching one cortex and not having a purchase anywhere else. Reaming is necessary at times for you to get a correct fit. Large sizes are needed depending on the size of the medullary canal. Occasionally you can have a 3-point fixation and not have a complete fit, but in that case you're likely to have a stem tip pain. So these are the basic differences. But what I would like to do now is to go through the different scenarios and understand that when we need stem, can you go for cemented or uncemented? So basically, when do you need stems? In revision scenario, 3 things. When there is a deficient bone, you want to augment your fixation. When there is deficient ligaments, bones are good, but your ligaments are deficient, you've now put a higher constraint, as Guru was saying. Now when you have a higher constraint, you're going to have more toggle forces on the implant, and therefore the implant has a higher chance of loosening, and therefore you want to augment it with a stem. Also, if there is a stress fracture that you're treating, so this we heard about the ORI classification. It's a good classification to start thinking because it will give you an idea of what you need to do. F1 simple, either tibia or, let's go one by one. F1, F2, F3, both either on the tibial or the femoral side. F1 is, there is a localized defect, either femur on the tibia, very easy to treat. You can use regular implants, you may not need a stem either. Or if you need, you can use metal augments and particulate bone to fill up the defect. In a revision scenario, there is a defect here, you can use a bone graft. It commonly occurs in a uni-revision When you end up making your cuts, the defect is so small, you can either use a bone graft or you can use cement. And here is this patient where the cement was used, standard component on the femoral side, PS, I always use PS, no higher constraint needed. And not only this, in this situation, you can balance it so well, I've used a mobile bearing implant. Now the mobile bearing revision implant, MBT tray, has a stem by itself. It's a longer component, and so you don't need an extra stem, but I would consider that this itself is a stem. And here is the patient. I used a wedge then, and the patient is at 15 years. Implant surviving, good range of movement. The only downside that the patient had was a patella alta baja because of the uni surgery. So limited range of movement of about 100 degrees, but otherwise surviving well. And so this is a common situation when you do revision of a uni. I use a cemented stem. This is a different implant, and therefore there is an extra stem put here. On the femoral side and on the tibial side. All unis don't need a stem on the femoral side, but tibia almost always. Now you can, if there is a, this should be F2. If there is a one side condyle gone, then you can use wedges, stem, cement, bone graft, but you always need a stem. You always need to augment it with a stem. This is a patient I had operated in 2001, young patient. By 2009, severe osteolysis. I think that this is one of those few batches of polyethylene which were not very good. Early osteolysis in 8-9 years, and I revised that using a sleeve on one side, stem on the other. I didn't put the stem here extra, just the sleeve because it has a long purchase. Cemented it completely in, and she's 10 years later doing well. This is again a mobile bearing revision, doing well in terms of function and activity. So particulate bone, again, F2, that means the condylar defect, either one condyle or both condyles, either on the tibia or on the femur. So here the condylar defect, single condyle on the tibia, you need a wedge, but you need to support it. I also had put a bone graft here. And these are the uncemented stem, long uncemented stems. Probably you could use a cemented stem as well here if you wanted to, but I thought in this scenario where you put a bone graft, it's better to put a long uncemented stem. Here is another scenario where I've built up tibia, the severe significant, the surgeon, probably primary surgeon, must have done an extra cut on that, and I wanted to build it up. 2 wedges, we don't get a block wedge here, but I use 2 wedges, cement in between, but stabilized it further using a long uncemented stem, cemented it in the proximal metaphyseal area. Don't cement it where the uncemented part starts, but the smooth part proximal to that, it's better to cement it in. So here is a type 2B defect on the femur side. Both condyles are missing. You can see that. And on the tibia, one condyle is missing. Wedge there. Whatever you do, 2 wedges I had put on the femur. You do need an extra cemented, uncemented stem. This is the canal fitting stem, which gives you your correct alignment on either side. And the type 3 defect where your severe bone loss, most of your ligaments are not working, you need to use hinges, metal augments, whatever else you use, you need stemmed to further stabilize it, except in some situations where you have sleeves. I'm not too sure about the cones because I don't use much of cones, but maybe with cones you will always need a stem. And also, most of the time it would be a cemented stem because you're anyway going to cement there into the cone. Might as well use a cemented stem. So this is the one such patient where the both side sleeves and long stems, giving me alignment and stability. So these are typical cemented and uncemented stems. The uncemented stems have this to get purchased. The cemented stem will have area where your cement pockets can be created. You would have, some of the designs will have a curved stem and also slotted stems, that is to reduce the stem tip pain at the tip of the stem, because that will take away some amount of pressure from the cortex. Now, one of the last thing that I wanted to leave you with is that remember that whenever you put in a revision situation a stem and your implant is fixed bearing, you're going to have forces that will transmit with particularly higher constraint onto the fixation area, and you'll have loosening. And therefore, I think the concept of using a mobile bearing in revision is important, because this rotational forces are diffused at the joint level and they are not transmitted to your fixation. Therefore, it protects your stem fixation. And Guruva showed that the incidence of re-revision is because of the aseptic loosening, mainly because of the toggle here. The stems have loosened in all these three patients because of the movement that occurs at the joint level. So these are the main reasons for the aseptic loosening. And bearing mobility will protect your fixation. Loosening is very rare with the rotating platform device, and I've been using it since 2008. More than 100 cases of revision with the mobile bearing. One such scenario, very heavy lady, post-op fracture, had 2 surgeries, single plate, then double plate, that got infected. And that's when I saw the patient. We revised it in 2 stages. Stems, mobile bearing implant, even in such a heavy patient, great function and good survival. She's even further. These are some other patients, 10-year post-surgery, 9-year post-surgery. Fixation remains stable, articulation is good. I would think a fixed bearing would have put some forces on the fixation by now. One last case, very interesting, that the patient had a primary surgeon did a revision in just 1 or 2 years, and the stemmed component, and this is, I'm showing this so that this is an uncemented stem with the primary surgeon had cemented it completely, and that's the nightmare. Taking that out is a nightmare, and it broke. That's when I saw her. It was a tough job because this came out easily, but getting that rest of the cement was really nightmare. Luckily, we have this intramedullary light source, and it helped me get every bit of the cement. It was such a long time that I then decided to do it in 2 stages. There was some doubt about infection, although it was not aseptic ultimately, but we did it in 2 stages. A long stem here, the tibial fixation was very good. However, that was in 2011, 6 years, you can see the X-ray, but ultimately 10 years later, now she loosened here. On the femoral side, she came with a severe pain and osteolysis there. What actually happened was that this screw had broken, connection to the TC3 implant. So this time the failure was on the femoral side, and I did a distal femur revision. Well, I think, and this you can have both. You can have uncemented, that's what this particular one is, but you could use it in a fully cemented manner this time. I think let's go skip that. I think in summary, I would like the mobile bearing implants in revision to prevent extra forces on your fixation on the stems. Most of the situation, you will be able to use both cemented and uncemented stems, but as I've gone through the criteria here, you can make your decision. Thank you.